So moving provider payment changes. Provider payment changes were one way that we actually paid for health reform. There were a lot of revenues needed in terms of coming up with the total tab of $930 billion for healthcare reform. I'm just going to focus on the ones that really focus on safety net hospitals, but there's a lot of other provisions that were in the bill. The biggest thing that my association and many of our members were concerned about are Medicaid payment rates and also what are called disproportionate share hospital dollars. Does everybody know what those are? So disproportionate share hospital dollars are basically a nod to hospitals that provide a disproportionate share of care to Medicaid and uninsured patients. And so they are given additional dollars to help them facilitate that mission. And so these dollars, the theory goes that if you insure everyone, you need less of these dollars. That's true to a point, right? But these dollars also help safety net providers given the fact that Medicaid rates are pretty abysmal throughout the country. So they help them make up for low Medicaid rates. Medicaid and Medicare DSH payments are going to be reducing as a result of the bill. The changes are going to start in 2014 and slowly ramp up. So they start about $500 million in 2014, $500 million in 2015, and then they go upwards. So a total of $14 billion. Now the hope is that as Medicaid DSH payments decline, coverage will increase, and somewhere in between that nexus, safety net hospitals will be okay. This is, enter Massachusetts, that you asked me to speak about. This is a really challenging proposition because you have to know what your Medicaid payments are going to be to know you're going to be okay as a safety net hospital. In Massachusetts, as part of the health reform debate, it was contemplated that there would actually be increases in Medicaid payment rates. Lo and behold, a recession enters. You have a budget crisis. None of those Medicaid increases occurred. So they are now finding themselves in Massachusetts in a perfect storm, where they had a decline in DSH payments to help pay for coverage expansion. They have low Medicaid payment rates. And additionally, those folks who are receiving subsidized health coverage, which in Massachusetts is called Commonwealth Care, they are being paid under their cost for those patients as well. So you can imagine, if the biggest bulk of your business is low-income patients, and they are in Massachusetts, Medicaid, Commonwealth Care, and some lingering uninsured, and you're getting paid below your cost for all of those individuals, and your DSH payments have been dramatically reduced, how do you keep going? This is the issue that has surfaced in Massachusetts. Virtually all of the hospitals that are high DSH payment hospitals in Massachusetts have sued the state and basically have suggested that, look, we're financing this coverage expansion, but we're not going to be able to keep our doors open. And that process is still weeding its way through the process. So there are some other changes in terms of Medicaid. As I mentioned, increase in primary care payments just for a short period of time, both in Medicaid and Medicare. It is interesting in the context of health reform. We're adding 16 million people to Medicaid. There was no major Medicaid reform and health reform. The only Medicaid reforms that were done were an increase in primary care payments. Okay, so why did that happen? Very early in the debate, we went to members of Congress, Senate, staff, you name it, and we said, look, what are we going to do about Medicaid? And they said, we can't deal with it. It's just too complicated. We've got 50 states, we've got 50 different programs, we've got to table that issue. We have a new commission that's coming online called MACPAC, and MACPAC is going to be the Medicaid commission that tries to sort all this out. One of the things we're going to be pressing hard on, and I hope all the advocates in this room will as well, is that we've got to figure out a way to have sustainable Medicaid rates for our providers. Otherwise, we're going to have 16 million people with a card who don't have access to care. I'm just going to gloss through some of these other ones. Both of the directors this morning mentioned that we are also moving to a payment structure where quality intersects with cost, right? We're not just going to be paying for services. Most of these changes are occurring via the Medicare program. But what happens, as you all know, is changes in Medicare drive changes in Medicaid. And so all of our hospitals are moving forward in terms of these changes. Value-based purchasing, which is the new term for pay for performance, special attention to why there's so many readmissions and an emphasis on reducing readmissions and penalizing hospitals for hospital-acquired conditions. I've touched on these things already. As I mentioned, hospitals now are thinking about, what their uninsured reduction is, what their Medicaid expansion is, how many exchange enrollees they're going to have, what their Medicaid payments are going to be, what their DSH reductions are going to be, and what their lingering obligation for the uninsured. It's the calculation of those things which tells you whether the safety net is going to be viable in the future. And I don't have a lot of details on a lot of those things. I don't know how DSH payments, I know how they're going to be reduced. I don't know how they're going to be distributed amongst hospitals. There is flexibility for the Secretary to do that.